Next is I would call upon the glaucoma specialist from Aravind Eye Hospital, Dr. George Puthuran, to deal with happiness post-cataract surgery in a patient with glaucoma. It's a very, very difficult and we have all would have experienced this, to convince a glaucoma patient to undergo any surgery, because the chance of burnout will be there. So Dr. Puthuran will enlighten us about how he tackles these patients.
Thank you very much. So cataract coexisting with glaucoma, obviously your goals are visual improvement, and patient also needs to be comfortable and symptom free. And I keep saying this, it is as much to do with setting the patient's expectation from the surgery as it is with the surgeon's knowledge and skill. And it's cutthroat professionalism here, has more to play than empathy and compassion. See, these are all some of my personal opinions. Always when we prepare a presentation, there is a mother article or there is a textbook chapter. Unfortunately here I had to do a lot of my experiences in this presentation, and I am proud to say it's almost 25 years since I have been taking care of such patients. And unique challenges of coexisting cataract and glaucoma. Patients are on glaucoma medications. Any clear-cut primary open-angle glaucoma or ocular hypertension with a cataract, you will feel it is absolutely normal, but you have to be very, very careful. These are diseased eyes. These have a ocular comorbidity other than cataract, and these are prone for choroidal effusions. Choriocapillaries can leak. It can even sometimes lead up with a suprachoroidal hemorrhage. Pseudo-exfoliation, angle closure disease, secondary open and closed angles, post-trabeculectomy, post-GDD, and the most difficult situation of nanophthalmos. I keep telling my fellows in the theater, difference between an in-the-bag IOL and an IOL in the sulcus is almost like, the difference is like heaven and hell. Every eye, I keep telling them, has to be the Prime Minister Narendra Modi's eye or your mother's eye. One immediate question that comes up is effect of prostaglandin analog use on the development of cystoid macular edema after cataract surgery. Everybody keeps asking this. Do you stop prostaglandins before cataract surgery? Do you continue prostaglandins after cataract surgery? I looked at literature. This is only 2 randomized prospective trials are there. This was in the British Journal of Ophthalmology. The group stopped prostaglandin in one arm of 30 patients, continued prostaglandin in the other arm of 30 patients. All the 60 patients were on prostaglandins preoperatively, and continuation, and these are eyes with normal macular morphology. These are not diseased eyes. Continuation of prostaglandin therapy following uneventful cataract surgery in eyes with normal macular morphology did not increase the risk of CME. And continuation of PGA, the secondary outcome measure was intraocular pressure control at the end of 1 month. Continuation of the prostaglandin analog led to a much better IOP control after a final follow-up. The second randomized control trial I found was in the JCRS. Again, latanoprost was continued in one arm. Latanoprost was discontinued in the other arm. They looked at 1 and 3 months. They looked at OCT macular thickness at the end of 3 months. Again, there was no significant increase in central macular thickness 3 months post-operatively with the use of latanoprost. Continuation of latanoprost after uneventful cataract surgery is safe. This is a meta-analysis again in the JCRS. They looked at multiple published literature. They analyzed using the stringent reporting of observational epidemiological studies. They analyzed with the strobe statement methodology. Again, no evidence supports stopping PGA use prior to or post-surgery to reduce CME. Again, caution should be exercised in complex susceptible patients, and these are the risk factors. In our practice, any patient who has a posterior capsular rupture or vitreous loss, any patient who is an uveitic patient, other eye had an uneventful cataract surgery but developed CME. These are some of the instances. Diabetes mellitus, even with the CSME, you look at the potential benefit and then continue the latanoprost. My only advice would be, I have no financial interest here, prefer a latanoprost over a travoprost or a bimetoprost. The periorbitopathy with latanoprost is much less, and you see there is a lot of loss of periorbital fat, deepening of lid sulcus. It becomes very difficult to do even a cataract surgery in some eyes on long-term bimetoprost. And all what we have seen over the past 15 years came up in a publication from the Asia Pacific Glaucoma Society guidelines last year. And they spoke exactly the same, that latanoprost is much more ocular friendly than travoprost or bimetoprost. A few tips to my junior colleagues here taking care of these high difficult eyes, especially these angle closure eyes, post-trabeculectomy eyes. Prefer to have a small volume, even a 1.5 ml of silocaine block, if it is given correctly in the subtenon space without any ballooning of the conjunctiva. It goes into the subtenon space, 1.5 ml, wait for some time. It's very comfortable to do a phaco in these patients. Again, I forgot to mention that initial decompression of the eye, initial decompression is take as much ever time as you want to do your first entry into the anterior chamber, both the paracentesis, because it is extremely important to have fine control of the anterior chamber. A sudden collapse of the anterior chamber can give you, your choriocapillaries can leak and it can be disastrous. Again, while inserting, always have the eye not too full with viscoelastic. When you put in your iris retractors, sometimes if it is very full, the iris is plastered to the anterior lens cap. So it's sometimes difficult to pick up the. Again, do not touch the pre-existing filtering bleb. It's extremely important. Even very good pre-existing filtering blebs still fail post-cataract surgery. Multiple publications, cataract surgery after trabeculectomy, you don't touch anything, beautifully controlled intraocular pressures with good avascular blebs suddenly become like this. Believe me, this was an avascular bleb. After cataract surgery, finally it went in for a tube, to the extent that sometimes when we have very avascular cystic blebs at the limbus, rather than doing a bleb revision, we sometimes do a cataract surgery and see whether the transient bleb leaks seal off. Tube shunts are more likely to have preserved function with subsequent cataract extraction than trabeculectomy with MMC. We also have our own results published on this. Extremely satisfying to have a cataract publication in a pre-existing Orolab aqueous drainage implant, where we showed that there was absolutely no significant rise in intraocular pressure or increased risk of RD failure after 2 years of follow-up. In doing an eye with a pre-existing GDD, usually it is, just don't think that there is a GDD there. Just continue your normal cataract surgery. Suppose you feel there is some kind of a fluctuation, you can use an iris retractor to tamponade the lumen of the tube before proceeding with the informed consent process. Is vital. Extends well and truly beyond what is documented and signed by the doctor, patient, or the attendant in a piece of paper. Some decisions have to be taken in consultation. See, this is an iridocorneal endothelial syndrome. Had a PSCC, nice PSCC in the visual axis. There is a high risk of corneal decompensation in these eyes, and naturally it ended up. But thing is, you need to give the option to the patient. You can give them the option of waiting for some time, or sometimes this happens. Again, another patient where an example where a decision has to be taken in consultation. This is post VR surgery, had an ACP doing well, but a nice posterior polar cataract has developed. Again, vision remains stable. You can always wait. That was what we would have advised. Just 1 minute I'll take. Happiness of the surgeon, I have also realized, is extremely important. At the end of the day, you need to have peace of mind. You need to be emotionally detached. Nowadays, the patient will say, my only daughter is getting married. I just want to say, you try to detach yourself, but try to do the best possible. I have also realized that not all battles can be won with intraocular surgery. We can only control the controllables. Medical science still has limits and clear-cut boundaries, and visual rehabilitation is also important. A process of losing vision in glaucoma is a very gradual process, but intraocular surgery can suddenly make the patient who walks into your chamber blind. This was a patient who had chronic hypotony reversed with supramid stenting. After cataract surgery, has 1/60 vision. The mother and the patient is coming and standing like this in front of me. Before cataract surgery, the patient's mother told me, see, this is my son. I have to lead him by hand and bring him to you. And if you hear that in Tamil or Malayalam, it will be much more striking. English doesn't actually convey the message. And this is my last slide. I still love what I do, even though it is not much less to do with worrying about very simple residual astigmatism and minor discomforts following cataract surgery. Ironically, the day before I was leaving from Madurai, my colleague comes to me and gives me a biryani packet. My colleague, I asked her why you have given it to me. She said one of my patients brought it to me today. It's an non-ophthalmic eye. I don't take non-vegetarian on Thursdays and Saturdays. And I asked her, how was the vision? She said the vision pre-operatively was perception of light. After surgery, it's hand movements. But the patient says, Moonji ella nalla theriyudu, madam. So I leave it at that. Thank you very much. And it's always a privilege to be in KSOS.
Thank you, Dr. George, for that excellent presentation. I'm sorry we didn't have many people to hear you. Yeah.
Very emotional talk.
It's very difficult to handle cataract in glaucoma because see any moment you can expect a wipeout, but then you will have to do a cataract surgery in that way. It's very difficult to tackle such patients, and you have done it well.